Morphine is a naturally occurring alkaloid of the morphine class. It functions as a central nervous system, depressant, and potent analgesic. It is derived from opium, which is sourced from the poppy plant, belonging to the Papaveraceae plant family and the Papaveroideae subfamily. Historically, the medicinal properties of opium, which contains morphine, alongside other psychoactive alkaloids such as codeine, have been recognized for millennia. Historians suggest that the Sumerians cultivated opium nearly 5,000 years ago, utilizing it to alleviate pain, both generally and following invasive medical procedures, such as amputations. However, a significant breakthrough occurred when the German pharmacist Friedrich Wilhelm Adam Sertürner successfully extracted morphine from the poppy plant. Interestingly, the exact year of his discovery remains a subject of historical ambiguity. For instance, the first edition of Goodman and Gilman's pharmacology text states that Sertürner isolated and characterized morphine in 1805 in Hanover, while the second edition claims this occurred in 1803 in Paderborn. Meanwhile, the seventh edition asserts that he formally reported the isolation of a pure opium-derived compound named morphine after Morpheus, the Greek god of dreams, in 1806. Despite this inconsistency, what remains undisputed is that Sertürner was the first to identify morphine as the principal psychoactive compound responsible for the pharmacological effects of opium. Although Sertürner's discovery was groundbreaking, his initial findings were largely overlooked until 1816, when he republished his work. A year later, in 1817, he refined his isolation method, devising a more efficient extraction process. His initial procedure had yielded not only morphine, but also codeine and trace amounts of other opium alkaloids. The improved method involved extracting opium with hot water and precipitating morphine with ammonia, resulting in the formation of colorless crystals that were poorly soluble in water, but readily dissolved in acids and alcohol. That same year, Sertürner's revised paper gained widespread recognition. In a French translation of his work, the renowned chemist Gay Lussac proposed renaming the compound from morphium to morphine. Morphine was initially manufactured in oral form as morphine acetate, an expensive and difficult to prepare salt. However, in 1831, Edinburgh-based physician and chemist William Gregory developed a more cost-effective and efficient method for isolating and purifying morphine salts. Even so, the widespread use of morphine did not occur until the development of the hypodermic needle and syringe in the 1850s, which allowed for intravenous administration. Until the early 20th century, opioids, including morphine, were freely available without a prescription. Recognizing the growing public health risks, governments worldwide began enacting regulations to control opioid distribution. In the United States, the Pure Food and Drug Act of 1906 marked the first step toward opioid regulation, mandating the proper labeling of substances such as morphine while prohibiting counterfeit drugs. Subsequently, the Harrison Narcotics Tax Act of 1914 introduced stringent regulations on the production, importation, and distribution of opioids, requiring physicians and pharmacists to oversee their dispensation. Further restrictions followed, including the 1924 ban on heroin, significantly curbing the recreational use of morphine and related opiates. Meanwhile, in Russia, the law on measures against opium smoking was enacted on June 7, 1915, as part of broader efforts to regulate narcotic substances. Despite increasing legal controls, morphine remained a primary analgesic throughout the 20th century, particularly during both world wars. However, between the 1930s and 1940s, the pharmaceutical industry saw the rise of alternative opioids, such as oxycodone, synthesized in 1914, and fully synthetic meperidine, synthesized in 1939, which gradually reduced morphine's dominance in clinical settings. The development of even more potent synthetic opioids, including fentanyl in the 1950s, further contributed to this shift. Nonetheless, morphine retained its status as a widely used analgesic, particularly in medical settings. In illicit markets, however, heroin, diacetylmorphine, became the opioid of choice. Still, in regions with limited heroin availability, morphine remained a common alternative for opioid-dependent individuals. One of the most significant centers of illicit opium and morphine production throughout the mid to late 20th century was the Golden Triangle, an area spanning northeastern Myanmar, northwestern Thailand, and northern Laos. This region dominated the global morphine and heroin supply until the early 21st century, when Afghanistan surpassed it in opium production. At the beginning of a new millennium, a remarkable discovery in 2003 confirmed the presence of endogenous morphine within the human body. For decades, scientists speculated about the existence of an endogenous opioid that would selectively bind to the mTOR3-opioid receptor found in human tissue. Studies eventually confirmed that certain human cells, particularly those responding to neuroblastoma, a form of cancer, contain trace amounts of naturally occurring morphine. More recently, in 2023, a drastic reduction in Afghan poppy cultivation occurred following the Taliban's crackdown on opium production. In some areas, including Helmand Province, poppy cultivation declined by 99%, with a 95% overall reduction nationwide. Consequently, Afghanistan lost its position as the world's leading opium producer, significantly impacting global opioid markets. Anyway, in this video, we will delve into one of the most influential opioid analgesics, morphine, which serves as the prototypical opioid against which all others are compared. As in previous analyses, we will explore all critical aspects of morphine, from its chemical properties, mechanism of action, and metabolism to its withdrawal syndrome and signs of overdose. Morphine is a naturally occurring opioid alkaloid that acts as a central nervous system depressant. For those unfamiliar with the distinction between opiates and opioids, the term opiate refers specifically to naturally derived compounds from the poppy plant, such as morphine or codeine. In contrast, opioids encompass both natural and synthetic substances that exhibit opioid activity in the brain. Similar to heroin, morphine belongs to the morphinane chemical class. Its molecular formula is C17H19NO3, indicating that it consists of 17 carbon, 19 hydrogen, and 3 nitrogen and oxygen atoms. Morphine has a molar mass of 285.34 grams per mole and exists in 2 optical isomers. However, in nature, only the levorotatory isomer, left-handed version, is present. The dextrorotatory isomer, right-handed version, can theoretically be synthesized in a laboratory, but it has no practical application. Unlike morphine, which provides analgesic, pain-relieving effects, the dextrorotatory isomer exhibits anti-analgesic properties, meaning it could heighten pain perception rather than alleviate it. Animal studies in rats suggest that this isomer does not bind to the mu-opioid receptor MOR, implying an affinity for a completely different receptor system. However, its precise pharmacological role, especially in humans, remains largely unknown. Morphine has a boiling point of approximately 190 degrees Celsius at standard atmospheric pressure. In its free base form, it appears as a brown, odorless powder, which is insoluble in water but dissolves in organic solvents. Interestingly, freebase morphine is nearly indistinguishable from freebase heroin in appearance. Morphine is primarily produced via extraction from the opium latex of the poppy plant, as illustrated in the figure on the right. Now, let's briefly discuss the extraction procedure of morphine. So, firstly, raw opium gum is dissolved in hot water and treated with calcium carbonate or calcium hydroxide. This step separates morphine from the plant material and impurities. The solution is then filtered and ammonium chloride is added, converting morphine into an insoluble base, which precipitates out of the solution. The morphine base can then be dissolved in hydrochloric acid, converting it into water-soluble morphine hydrochloride, the form used in medical applications or recreational settings. While morphine can also be synthesized in a laboratory via total synthesis, this method is far less practical. The first successful total synthesis of morphine was accomplished by Gates and others in 1952 with additional methods, such as the rice synthesis, having since been proposed. However, due to morphine's complex stereochemistry and polycyclic structure, synthetic production remains highly inefficient and cost-prohibitive. Poppy-derived extraction continues to be the most economical and widely used method of production. Here we have the composition of the primary alkaloids present in raw opium. For context, the latex of the opium poppy contains over 100 benzylisoquinoline alkaloids, all of which are biosynthesized from the amino acid L-tyrosine within the plant itself. Raw opium possesses a chemically intricate composition, consisting of sugars, proteins, lipids, water, meconic acid, plant waxes, latex, gum, ammonia, and sulfuric and lactic acids, along with a diverse range of alkaloids. These alkaloids are broadly classified into two primary chemical groups, phenanthrines and benzylisoquinolines. The principal phenanthrines include morphine, codeine, and thebaine, with morphine being the predominant alkaloid found in opium. That said, the precise composition and concentration of these alkaloids may vary significantly between different cultivars of the poppy plant. Additionally, variations in seed yield per plant and latex yield per plant have been observed. Despite these differences, the average percentage of major alkaloids in dried raw opium sourced from Southeast Asia is as follows: 11.4% for morphine, 8.1% for noscapine, 3.5% for codeine, 3.2% for papaverine, and 3.1% for thebaine. As a final note, in order to produce 1 kilogram of morphine, you would need around 10 kilograms of raw opium, highlighting the need for large-scale processing for opiate production. Morphine exhibits route-dependent bioavailability, with buccal administration achieving approximately 18.7% bioavailability, while ingestion yields a significantly higher 40%. As expected, intravenous administration ensures complete bioavailability due to direct entry into the systemic circulation. The time to reach peak plasma concentrations varies between 90 minutes for oral ingestion and 4 to 8 minutes for intravenous injection. The onset of action for oral use can range between 30 to 120 minutes, depending on whether immediate release or extended release formulations are used. On the other hand, the onset of action for intravenous use is approximately 8 seconds for the initial rush, with peak effects manifesting within 1 to 2 minutes. As for the average duration of action, morphine's impact typically lasts between 3 to 6 hours for oral administration and 3 to 5 hours for intravenous administration. Furthermore, morphine exhibits a moderate plasma protein binding profile, with 20 to 35% of the drug binding to plasma proteins after entering the systemic circulation, regardless of the route of administration. The metabolism then occurs in the liver, brain, and various peripheral tissues, while excretion is predominantly facilitated by the renal system, with 90% of the drug being excreted via urine, while the remainder is eliminated through biliary excretion. When discussing morphine's pharmacological properties, it is essential to recognize the role of its pharmacologically active metabolite, morphine 6-glucuronide, abbreviated as M6G, which contributes to morphine's overall effects. However, even with its contribution, morphine itself remains the primary agent responsible for its characteristic psychophysiological impact. This is largely due to the fact that only about 10% of metabolized morphine is converted into M6G, meaning that at lower doses M6G's pharmacological influence remains negligible. In any case, focusing on morphine itself for now, its pharmacodynamics closely resemble those of heroin, as illustrated in the accompanying figure on the right side. Morphine functions as a full agonist at the mu-opioid receptor, activating both the G-protein coupled and beta-arrestin signaling pathways. This interaction elicits the full spectrum of opioid effects, including analgesia, euphoria, sedation, and adverse effects such as constipation and respiratory depression. Additionally, morphine also exhibits affinity for delta opioid receptors and kappa opioid receptors, on which it also acts as an agonist, though with significantly reduced potency and affinity compared to its action at MOR. Despite this, research suggests that some of morphine's effects, such as spinal analgesia and dysphoria, are at least partially mediated via DOR and KOR activation. Beyond opioid receptor modulation, morphine also influences GABAergic and dopaminergic neurotransmission. Specifically, it affects GABAergic projections between the rostromedial tegmental nucleus and the ventral tegmental area, VTA, where it binds to MOR receptors situated at GABA interneurons, which decreases GABA activity, resulting in elevated dopaminergic activity. This disinhibition of dopaminergic neurons within the mesocorticolimbic pathway, which projects from the ventral tegmental area to the nucleus accumbens, NACC, leads to increased dopamine release, reinforcing reward-related behavior and contributing to the development of psychological dependence. Additionally, morphine also binds to mTOR receptors within the locus coeruleus, LLC, the brain's principal noradrenergic center, where it suppresses noradrenaline production, thereby inducing profound sedation and relaxation. Moreover, since morphine mimics endogenous opioids such as endorphins, it can bind to and activate hedonic hotspots within the brain, promoting intense euphoria and pleasure. However, chronic morphine use leads to neuroadaptive changes, including the downregulation of endogenous opioid activity. Over time, the brain compensates by reducing endorphin production, which may result in anhedonia upon cessation, as there is an insufficient amount of endorphins available to activate hedonic hotspots. Compounding this issue, dynorphin activity spikes, driving stress responses, dysphoria, and anxiety. Lastly, morphine also modulates the activity of the histaminergic system by increasing histamine release, which leads to vasodilation, decreased blood pressure, and itching, a common side effect associated with opioid use. As mentioned in the previous section, morphine's pharmacological effects are influenced, albeit to a lesser extent, by its active metabolite, morphine 6-glucuronide, abbreviated as M6G. This metabolite exhibits a pharmacological profile closely resembling that of morphine, sharing similar receptor interactions and the overall mechanism of action. Like morphine, M6G functions as a full agonist at the mu-opioid receptor, also known as the MOR receptor, displaying a nearly identical binding affinity and comparable efficacy in receptor activation. Interestingly, emerging research suggests that M6G may act as a biased MOR agonist, favoring beta-arrestin 2 signaling over G-protein coupled pathways. If confirmed, this property could indicate a more favorable clinical profile than morphine, as biased agonists have been hypothesized to produce fewer adverse effects, particularly respiratory depression. That said, conflicting research suggests that biased MOR agonists may still elicit the same adverse effects as traditional balanced MOR agonists like morphine, with the key difference being the dosage required to induce them. In this case, higher CNS concentrations of biased agonists might still result in respiratory depression and other opioid-related adverse effects. Given these uncertainties, further research is necessary to definitively determine whether biased MOR agonists have indeed a more favorable clinical value and whether M6G functions as a biased MOR agonist. Beyond its MOR activity, M6G also exhibits agonistic action at delta opioid receptors, also known as DOR receptors, albeit with an affinity 6 times lower than that observed at MOR. However, M6G's efficacy at DOR is still higher than that of morphine itself. Additionally, M6G interacts with kappa opioid receptors, also known as KOR receptors, though its binding affinity and efficacy at this receptor are minimal. Nevertheless, at elevated CNS concentrations, M6G's interaction with the KOR receptor becomes somewhat pharmacologically relevant, yet even under such conditions, its primary receptor targets remain MOR and, to a lesser degree, DOR receptors. Before proceeding forward, let's examine the figure on the right, which illustrates the pharmacological genetic model of opioid receptor function. As depicted, opioid agonists with strong MOR activity induce anti-stress response and euphoria. Moreover, compounds with predominant DOR agonism tend to enhance mood and produce anxiolytic effects. Conversely, potent KOR agonists are associated with dysphoria, anhedonia, and stress responses. Morphine undergoes primary metabolism in the liver, though its biotransformation also occurs to a lesser extent in the brain, kidneys, and other tissues. As illustrated in the figure on the right, the principal enzyme responsible for morphine metabolism in humans is UGT2B7. This enzyme is expressed in multiple organs, including the liver, intestines, kidneys, pancreas, and brain. UGT2B7 facilitates the conversion of morphine into its two primary metabolites, morphine 3-glucuronide, abbreviated as M3G, and morphine 6-glucuronide, M6G. Among these, only M6G is capable of crossing the blood-brain barrier into the brain, where it exerts significant opioid effects. In contrast, M3G is largely unable to penetrate the central nervous system under normal physiological conditions, and thus lacks opioid activity. However, in individuals with renal impairment, M3G may accumulate systemically, leading to seizures, hallucinations, or even coma. This suggests that at sufficiently high concentrations, M3G can breach the blood-brain barrier despite its strong polarity, which normally restricts CNS penetration. Animal studies further propose that M3G may interact with glycine or GABA receptors, though its precise pharmacological role, particularly in humans, remains poorly understood. As further depicted in the figure, beyond UGT2B7-mediated metabolism, a minor fraction of morphine is also metabolized by the CYP3A4 enzyme, found predominantly in the liver and intestines. This pathway leads to the formation of secondary metabolites, such as normorphine and hydromorphone, though their clinical significance remains limited. Additionally, UGT1A enzymes, particularly UGT1A1, UGT1A3, UGT1A6, UGT1A8, and UGT1A9, contribute marginally to morphine metabolism, primarily within the gastrointestinal tract and liver. Despite their involvement, their overall impact on morphine clearance is relatively minor. It is important to note that morphine's metabolic rate can vary between individuals, influenced by genetic polymorphisms affecting enzymatic activity. For instance, contemporary research suggests that variations in the UGT2B7 gene can either enhance or diminish morphine clearance, thereby altering systemic metabolite concentrations. One study found that Chinese patients exhibited a higher clearance rate of morphine, leading to increased systemic levels of its metabolites. Conversely, research indicates that older individuals may experience a decline in morphine clearance due to age-related enzymatic changes, though this effect has been deemed clinically insignificant in medical settings. However, its implications for recreational use remain uncertain. Unlike heroin, morphine undergoes exclusively phase 2 metabolism, primarily via conjugation processing. However, a minor fraction is also subject to sulfation and N-demethylation, contributing to the formation of additional metabolites. Because morphine bypasses phase 1 metabolic processing, unlike heroin or codeine, the likelihood of metabolic interactions with other substances is significantly lower. However, it is crucial to recognize that morphine is still susceptible to pharmacodynamic interactions. For instance, co-administration with other CNS depressants, such as other opioids or benzodiazepines, can potentiate its effects, increasing the risk of overdose. Now, let's briefly examine the 3 key metabolic pathways involved in morphine biotransformation, all of which lead to the creation of several metabolites depicted in the figure. So the first pathway, called the conjugation process, leads to the formation of 2 primary metabolites, morphine 3-glucuronide and morphine 6-glucuronide. Sulfonation is another metabolic pathway, resulting in the production of morphine 3-sulfate and morphine 6-sulfate, both of which appear to be pharmacologically inactive. The final N-demethylation route then generates 4 inactive metabolites: normorphine, normorphine 6-glucuronide, morphine 3,6-diglucuronide, and morphine ethereal sulfate, as well as one active metabolite, hydromorphone. Here it is worth noting that hydromorphone is a potent opioid, estimated to be approximately 5 times more potent than morphine when administered intravenously on a dose-equivalent basis. Nevertheless, in practice, the amount produced by morphine's biotransformation is too insignificant to induce a measurable pharmacological effect. Among the various methods of morphine administration, intravenous injection remains the most prevalent, albeit also the most hazardous due to its association with a heightened risk of overdose. In contrast, oral consumption, while considered the safest route, is relatively uncommon among recreational users. This method is primarily limited to those who obtain pharmaceutical-grade morphine tablets, as illicitly sourced morphine is more often available in powdered freebase form or some salt, such as hydrochloride or sulfate, which is poorly suited for oral ingestion. However, some users circumvent this limitation by encapsulating powdered morphine in gelatin capsules for consumption. Intramuscular injection represents another potential mode of administration, though it is seldom utilized due to the significant risk of localized inflammation and tissue damage at the injection site. Morphine can also be vaporized and inhaled by heating it on a surface, such as aluminium foil, or in a specialized pipe. However, this method is only viable with freebase morphine, making it both impractical and uncommon. Additionally, pulmonary exposure carries inherent risks, including potential lung damage. The second safest route of administration is intranasal insufflation. Despite this, it remains an infrequent choice among users due to morphine's relatively low intranasal bioavailability, approximately 10%. This necessitates substantially higher doses to achieve the desired effects. Nonetheless, compared to intravenous or intramuscular routes, intranasal use is associated with a lower incidence of severe adverse effects. 2 additional, albeit exceedingly rare methods of administration include rectal and vaginal absorption. Although practical user reports on these routes are virtually non-existent, the pharmacological principle suggests that morphine salts could be absorbed through mucosal membranes in these regions, facilitating systemic distribution. Not surprisingly, as illustrated in the accompanying figure, the selected route of administration significantly influences the pharmacokinetic profile of morphine, particularly its systemic distribution and eventual transport to its primary site of action, the central nervous system. Now, let's briefly examine the approximate dosing of oral and intravenous morphine sulfate in opioid-naive individuals. You might be wondering why I haven't included dosing ranges for alternative routes of administration this time. The reason is simple. There is a lack of sufficient user reports and studies on dosing for alternative methods. Additionally, most morphine users tend to prefer either oral or intravenous administration anyway, making these the most relevant to discuss. It is also important to emphasize that these dosing ranges are provided for educational purposes only and should be taken with a considerable degree of skepticism. Anyway, let's start with dosing for the oral method. So the threshold dose is between 1 to 5 milligrams. A light dose is 5 to 10 milligrams, while a common dose ranges between 10 to 20 milligrams. A strong dose is 20 to 30 milligrams, and a heavy dose corresponds to a range between 30 to 40 milligrams. Lastly, an excessive dose is 40 milligrams or more. As a bonus, the estimated lethal dose for 50% of the population, LD50, in an opioid-naive individual is approximately 100 milligrams or more when taken orally. As for the dosing of an intravenous method, a threshold dose ranges between 1 to 2.5 milligrams, while a light dose goes between 2.5 to 7.5 milligrams. A common dose lies between 7.5 to 10 milligrams. A strong dose then ranges from 10 to 15 milligrams, and a heavy dose stands at 15 to 20 milligrams. Additionally, an excessive dose corresponds to 20 milligrams and more. Lastly, the approximate LD50 for intravenous administration is around 50 milligrams or more. In any case, it is crucial to remember that both LD50s are only rough statistical estimates that do not account for all individual differences. If you're interested, feel free to pause the video and review the estimated dosing ranges for oral and intravenous pure morphine sulfate in individuals with light to moderate opioid tolerance. In any case, before moving forward to the next chapter, I will just briefly add that the LD50 in individuals with a moderate tolerance stands at 250 milligrams or more for the oral method, while for intravenous use it is around 125 milligrams or higher. The duration of action of morphine varies depending on the route of administration, with oral consumption producing the longest lasting effects, albeit at a lower intensity compared to other methods. It's also important to note that oral duration is influenced by the specific formulation used. For instance, extended-release medical morphine tablets provide a longer overall effect compared to orally used illicit morphine hydrochloride sulfate powder. Additionally, several factors may further influence the duration of action, including dosage, individual differences, and pharmacokinetic interactions with other substances, which may increase systemic morphine availability, thereby potentially affecting its overall duration of action. Anyway, if you're interested, feel free to pause the video and review the approximate duration of action for oral and intravenous morphine sulfate in opioid-naive individuals using a common dose, 10 to 20 milligrams orally and 7.5 to 10 milligrams intravenously. The psychological effects of morphine vary in intensity depending on the route of administration and dosage. Lower oral doses typically induce a mild elevation in mood, accompanied by mental relaxation and slight social disinhibition. In contrast, higher intravenous doses can trigger a rapid and intense euphoric rush, followed by profound sedation and cognitive fatigue. The positive psychological effects associated with morphine consumption may include euphoria, mood elevation, anxiety suppression, mental relaxation, and enhanced sociability. Moreover, neutral effects may then encompass drowsiness and dream vividness. Conversely, adverse psychological effects may include compulsive redosing, ego inflation, irritability, delusions of sobriety, reduced cognitive acuity, agitation, paranoia, and heightened aggression. The intensity of morphine's physiological effects is again influenced by the route of administration and dosage. Lower doses typically invoke mild muscle relaxation and moderate analgesia, whereas higher doses often elicit a profound state of physical euphoria, characterized by a tingling sensation and deep muscle relaxation encompassed by feelings of warmth spreading throughout the body. The positive physiological effects of morphine may then include analgesia, physical euphoria, cough suppression, and muscle relaxation. Furthermore, neutral physiological effects may encompass meiosis, increased perspiration, itching, appetite suppression, urinary retention, dry mouth, and bradycardia. On the other hand, adverse physiological effects can manifest as respiratory depression, severe constipation, dehydration, hypertension, nausea, vomiting, hot and cold flashes, decreased libido, temporary erectile dysfunction, orgasm suppression, skin flushing, seizures, and in case of severe overdose, coma. At high doses, morphine intoxication can induce visual disturbances, including blurred or double vision, wherein the eyes involuntarily shift between focus and defocus. These perceptual irregularities persist regardless of where one directs their gaze, impairing the ability to engage in visually demanding tasks such as reading or driving. Moreover, high doses may elicit internal hallucinations, often characterized by a dreamlike state, semi-consciousness, and vivid hypnagogic imagery. In some cases, these hallucinatory experiences may escalate to level 3 intensity, wherein individuals perceive fully formed, immersive hypnagogic visuals. Beyond these internal hallucinations, a state of dissociation may also manifest, especially when morphine is administered intravenously. While this dissociative state can be profound, it remains less intense than the dissociation induced by classical dissociatives such as ketamine or phencyclidine, PCP. This effect in particular might be enhanced when combining morphine with other substances, including cannabinoids, psychedelics, and dissociatives. Withdrawal from morphine typically manifests within 8 to 24 hours following cessation of use. The severity of withdrawal symptoms can range from moderate to severe, depending on factors such as duration of use, daily intake, and individual differences. As with other opioids, morphine withdrawal encompasses both psychological and physiological components. Altogether, morphine withdrawal consists of 3 distinct phases. The initial acute phase, lasting between 8 to 72 hours, is marked by the highest intensity of psychophysiological symptoms. Physiological manifestations include diarrhea, muscle cramps, and autonomic dysregulation, while psychological symptoms encompass cravings and heightened anxiety. The second phase, known as subacute, then lasts between 4 to 10 days. During this stage, physiological symptoms persist but gradually diminish in intensity. However, psychological distress, including anxiety and cravings, may linger. Even so, the overall symptom burden progressively declines throughout this phase. The protracted phase is the last stage of morphine withdrawal, lasting for up to 6 months or longer. This final phase, primarily observed in long-term heavy users, is characterized by persistent psychological symptoms such as moderate cravings, mood disturbances, including anhedonia and depression, and impaired cognitive control. These factors heighten the risk of relapse, particularly in response to stressors or emotional instability. Notably, individuals with light to moderate morphine use typically do not experience this prolonged phase. The neurobiological underpinnings of morphine withdrawal mirror those of heroin withdrawal. Essentially, with prolonged morphine use, the opioid system undergoes adaptive changes, including the upregulation of kappa opioid receptors and increased dynorphin activity. This heightened activation of CoA receptors suppresses dopaminergic signaling, leading to withdrawal symptoms such as diminished motivation and anhedonia. Another key mechanism involves noradrenergic dysregulation, characterized by excessive noradrenaline release in the locus coeruleus, abbreviated as LC, upon abrupt cessation. To better grasp this process, refer to the first figure on the right, which illustrates the impact of acute and chronic morphine exposure on noradrenergic function. Under normal physiological conditions, adrenergic neurons in the LC regulate wakefulness, respiration, blood pressure, and alertness. The MOR opioid receptors present in these neurons mediate morphine's effects by inhibiting adenylyl cyclase, abbreviated as AC, an intracellular enzyme, thereby reducing the production of the secondary intracellular messenger cyclic adenosine monophosphate, abbreviated as CAMP. This suppression ultimately leads to decreased noradrenaline release, producing the characteristic effects of acute opioid intoxication, such as sedation, respiratory depression, hypertension, and muscle relaxation. However, with sustained opioid exposure, LC neurons undergo compensatory adaptations, gradually restoring CAMP levels to baseline despite continued opioid presence. Consequently, when morphine administration ceases, it is then followed by a compensatory surge in CAMP production and excessive noradrenaline release. This neurochemical rebound manifests as opioid withdrawal syndrome, characterized by symptoms such as muscle spasms, anxiety, and generalized discomfort, Beyond noradrenergic dysregulation, morphine withdrawal is also influenced by elevated corticotropin-releasing factor CRF, which stimulates the hypothalamic pituitary adrenal HPA axis, exacerbating physiological stress responses. Moreover, as illustrated in the second figure on the right, withdrawal is further driven by neuropeptide imbalances, including increased activity of substance P, a neuropeptide associated with heightened pain sensitivity, anxiety, and nausea. Other neuropeptides also contribute to withdrawal pathology, but exploring them in depth would require an entirely separate discussion. Therefore, I will instead move on to the morphine withdrawal syndrome treatment. The approach to treating morphine withdrawal closely parallels that of heroin dependence. The severity of withdrawal symptoms dictates the choice of intervention, where heavy users are typically put through pharmacological detoxification involving the administration of long-acting opioid substitutes such as methadone or buprenorphine. For individuals with severe dependence and withdrawal, these medications may be administered over an extended period to alleviate persistent withdrawal symptoms and mitigate intense cravings during the initial months of abstinence. In order to enhance treatment efficacy, substitutional pharmacotherapy is typically combined with psychotherapeutic interventions, most notably cognitive behavioral therapy, CBT, which has demonstrated the highest success rates when combined with pharmacotherapy. Beyond CBT, additional psychosocial interventions, such as group therapy, may be incorporated to support reintegration into daily life and reduce the risk of relapse. This multifaceted approach enhances long-term recovery outcomes by addressing both the neurobiological and psychological aspects of morphine dependence. Now, let's briefly examine the psychophysiological symptoms of morphine withdrawal, beginning with psychological symptoms. These may include intense drug cravings, heightened agitation, anxiety, depression, restlessness, irritability, paranoia, and vivid dreams, often in the form of distressing nightmares. On the physiological side of things, withdrawal can induce nausea, diarrhea, muscle cramps, generalized musculoskeletal pain, photophobia, pupillary dilation, and autonomic hyperactivity. A key factor underlying certain withdrawal symptoms, such as heightened anxiety, elevated blood pressure, and pupillary dilation, is dysregulation of the hypothalamic pituitary adrenal HPA axis, as illustrated in the figure on the right. During the acute withdrawal phase, the hypothalamus releases corticotropin-releasing hormone, abbreviated as CRH, which subsequently stimulates the pituitary gland to secrete adrenocorticotropic hormone, abbreviated as HTH. HTH then activates the adrenal glands, leading to the release of adrenaline and cortisol. This surge in cortisol signals the hypothalamus to restart the cycle, perpetuating the stress response. Over time, as withdrawal progresses, HPA axis activity gradually subsides, eventually returning to a homeostatic state. This video analysis of morphine would obviously not be complete without addressing its potential pharmacokinetic and pharmacodynamic interactions with other substances, along with their respective risk categories. These interactions can give rise to a wide range of predominantly adverse psychophysiological effects, some of which might be rather severe in their manifestation. Nevertheless, rather than delving deeper into this subject area, I will proceed to the final chapter of today's video. Anyway, if you are interested, feel free to pause here to review the provided information at your own pace. And just a quick note, the plus sign in brackets indicates an increase in the intensity of certain psychophysiological effects, whereas the minus sign signifies a reduction in these effects. I should also mention that the presented table does not contain an exhaustive list of all potential adverse psychophysiological reactions. Instead, it only touches on more commonly reported ones. Before concluding, let's briefly examine the key psychophysiological manifestations of morphine overdose. Psychological symptoms may include euphoria, dysphoria, excessive sedation, heightened anxiety, and paranoia. On the physiological side, An overdose can precipitate severe respiratory distress, respiratory depression, hypoxia, hypopnea, and profound hypotension. Fortunately, opioid overdoses can often be rapidly reversed with the administration of naloxone or naltrexone, potent opioid antagonists that effectively displace morphine from opioid receptors, counteracting its effects almost immediately when given intravenously. However, it is important to note that in individuals with opioid dependence, these antagonists can precipitate acute withdrawal, which, while not typically fatal, can be intensely distressing. For a broader perspective, take a look at the figure on the right, which illustrates estimated global opioid-related mortality in 2024. As evident, the United States ranks highest, with an annual opioid overdose death rate of 15.4 deaths per 100,000 individuals. Canada follows closely, reporting 6,900 opioid-related deaths per 100,000 individuals, while Russia records approximately 3,000 deaths per 100,000 individuals. These statistics underscore the widespread nature of the opioid crisis, with a significant proportion of fatalities attributed to synthetic opioids far more potent than morphine, primarily fentanyl, and its even more potent analogues, like carfentanil. In any case, that concludes today's discussion. If you found this analysis informative, don't forget to like the video and subscribe to the channel. For those interested in further exploration of various other substances, check out the Drug Library portal, linked in the video description below. In our next video, we'll delve into one of the most potent and dangerous opioids, fentanyl.